So today we are going to talk about stroke. Stroke is a very serious medical emergency, and as nurses we want to be able to identify the different types of stroke, and more importantly we want to be able to identify when our patient has some of the signs and symptoms of a stroke. So let's start out by just kind of talking about what a stroke is. So a stroke is an infarction. And so when narrow arteries become blocked and the blood supply to an organ is stopped, organ damage results. And this damage is called infarction. And if you remember from other lectures, we've said that infarction is irreversible because cell death occurs in an infarction. Ischemia is reversible. So when we have an ischemic event and blood flow is temporarily not available and then it is restored, we have a regaining of whatever was that we thought we might be losing, right? That the blood supply was not stopped long enough to cause cell death to occur. So ischemia is reversible. So in strokes, we're first going to talk about what a TIA is. So a transient ischemic attack is a stroke that lasts less than 24 hours and is completely reversible. You'll also hear this referred to as a mini stroke. And so the RIND type of stroke, this is a reversible ischemic neurologic deficit. This is a stroke that lasts from a day to a week and is completely reversible. So very few people actually use this term, but it's important to differentiate between a TIA, in which the symptoms usually resolve within 24 hours, and one of these strokes where the symptoms can last from a day to a week and then completely reverse. So in a full stroke, a CVA, cerebrovascular accident, or cerebral infarction, these words all mean the same thing. The infarction results in permanent damage to the brain. And so we've talked about hypertension causing brain damage. Hypertension is a major cause of TIAs and strokes. And so you'll hear it referred to in these different ways: a brain attack, a CVA, a cerebral infarction. And one of the things that happens is our internal carotid arteries can start to develop plaque. And so if a piece of that plaque breaks free and travels up into the brain and blocks a blood vessel that supplies the brain with blood, what we have then is an embolus, right? So the plaque breaks off, it becomes an embolus, it travels up into the brain, into smaller and smaller arteries until it lodges into a small artery and it blocks the flow of blood. And so here we can see an example of where there is a clogged artery. And then up above that area where the artery has been clogged, we can see that there is cell death, right? Because the blood is not being able to supply the tissue up above where the artery has infarcted. In this picture, we're learning about a brain bleed. This is also referred to as a hemorrhagic stroke. So what happens here is that there's a pressure in a blood vessel that's causing them to weaken and kind of balloon out, like you see in this image here. And what happens is if the pressure gets high enough, there can be a bursting open, a ruptured aneurysm in which there is bleeding that takes place in the brain tissue. And this is equally as disruptive to the brain tissue as an infarction can be. And so one of the treatments for this is they can go in with a surgical clip to stop the bleeding in the brain. And so here you can see they've kind of gone in and they've clipped off the ruptured aneurysm to stop that bleeding. The other thing we can do, if we know that we've got some carotid arteries that are full of plaque, the surgeon can go in and do a surgery called a carotid endarterectomy, where they actually clean the plaque out that is in the carotid arteries. And so we can hopefully then prevent a piece of plaque from breaking off and going up into the brain and causing a stroke. Another major cause of transient ischemic attacks and strokes is atrial fibrillation. We've talked about atrial fibrillation before. Atrial fibrillation is when the atrium of the heart kind of sit there and quiver. And so when they're fluttering and quivering, what happens is the blood that is in there tends to clot. And we know that when blood clots, then we have an increased risk for one of those clots getting thrown out into the circulation and causing a stroke. So this is one of the major reasons that we use the drug Coumadin. Remember, Coumadin does not dissolve clots. Coumadin is just a drug that supports the body from developing new clots. And so we don't want to convert AFib to a sinus rhythm until we know that there's no thrombus in those atrium, right? Because if we convert AFib to a sinus rhythm, we might end up causing one of those clots to get released. And so just to review, part of a thrombus may break off and become an embolus. The embolus travels through the blood stream until it reaches a vessel too small for it to pass through, and then we have a blockage. Emboli commonly come from the heart, where different diseases can cause thrombus formation, and atrial fibrillation is the one that we are covering right now. So what we can do to make sure that there are no clots in those atrium is something called a transesophageal echocardiogram, where we can kind of get a good view of the atrium, and we can locate these clots. And we can treat the patient by putting them on Coumadin, waiting for the body to do its natural thing and dissolve these clots before we convert that rhythm. And so the other option is to do fibrinolytic therapy, and in this case we are actually dissolving a clot. Retivase is a drug that we use to dissolve thrombus associated with MI. It can also be done for a thrombotic stroke as well. Okay. So those are some of the therapies that we use to treat. Let's talk about the warning signs of a stroke. A stroke is a medical emergency. We need to be able to identify what's happening and call for help. This is kind of a good acronym to remember. Be FAST for signs of a stroke. We want to identify if the patient's having problems with balance, if there's a sudden visual change, facial drooping, arm weakness, problems with their speech. And in terms of time, we don't want to stall, we want to call. So we want to get a note for the time the symptoms start, and then we want to get help to arrive as soon as possible. So let's look at these in a little more detail. When we talk about a sudden change in balance or coordination, we're looking for a complaint of dizziness, perhaps, also called vertigo. We wanted to be sure that our patient, maybe we never even heard of a complaint of balance, dizziness or vertigo, but the individual fell down, right? And so this would be a sign that maybe they're having a stroke. There can be visual changes, sudden loss of vision, double vision. Anopsia is a loss of vision, and in this photograph here, it kind of shows the type of vision loss that they might say they're experiencing, where they kind of lose half of the visual field. So you can see here what the patient is seeing is only kind of like half of this photograph in this picture. And we're going to talk more about that a little bit later on. Drooping of the face. So the face looks uneven. Another way to describe this is asymmetry in the face. If you look very carefully at this woman, you can see that she's got some facial drooping. And so these are the types of things that we want to look for in a patient maybe that's complained of dizziness or complained of a change in their vision. We then want to look closer at them to see if they're having any kind of facial paralysis or weakness. A weakness of the arms, this could be a sudden numbness. They could say that they're experiencing numbness or tingling, and then we can check for arm drift. And so what we have them do is close their eyes and extend both of their arms straight out with their palms up. We want them to try to hold that out for 10 seconds. And normally both arms will stay in that position, right? However, if they're having a stroke, they could have a drift where one of the arms tends to drift downwards. So this is another sign that you can look for. Slurred speech, or a sudden difficulty speaking or understanding others. So if the individual all of a sudden has trouble speaking, or just says that they're confused, they don't understand what you're saying to them, we want to be on alert. A trouble speaking is called aphasia, and there are different types of aphasia that we're going to talk about. One of the things we can do is ask the patient to repeat something to us, like tell us to repeat something back. If they use correct words to describe things, that's considered normal. But if they start to slur their speech and they start saying things that don't make sense to us, then we might be concerned that they're having a stroke. Okay? The other thing that you might hear people complain of is the worst headache of their life, cephalgia. They might say, I have the worst headache I have ever had in my entire life. This can be a warning sign that someone is having a stroke. So don't stall, call. We want to make a note of the time that the symptoms began, and we want to call 911 and get the person to the ER as soon as possible, because we know that the quicker we can get them treated, the more brain tissue we can save, right? Because just like with the myocardial infarction, time is muscle, right? When a patient is having a stroke, time is really brain muscle, brain function. And so the longer that infarction is there causing cell death, the more deficits they might have. The sooner we could get in and do an intervention where we use Retivase for clot dissolving, or in the case of an aneurysm, they go in and do the clipping, the less damage that happens. So we're going to talk about some terms now associated with stroke. Paresis versus plegia. Paresis means weakness. Plegia means paralysis. And so someone might say that the patient has plegia or paralysis when the weakness is so severe that they can barely move the limb, okay? And so there can be different levels of weakness, right? And so we want to make sure if they've just got some weakness and they can still have some movement, that's one thing. But if they're at the point where they really have little or no movement at all, that's considered paralysis. And so hemiparesis means weakness on one half of the body, and hemiplegia means paralysis, or again, severe weakness on one half of the body. We know that sensory loss can happen in a stroke. Sensory loss is called anesthesia. And so an hemianesthesia is a sensory loss on one half of the body. And we know that the cerebral cortex of one side of the brain, okay, controls and senses the opposite side of the body, okay? And we learned about this in our intro to neuro lecture. So the cerebral cortex on one side of the brain senses and controls the opposite side of the body. So infarction of the cerebral cortex of one side of the brain will affect the opposite side, also called contralateral side of the body, both sensory and motor. So let's talk about homonymous hemianopia. Homo meaning same, nomos meaning name as in left or right, hemi meaning half, an meaning without, and opia or opsia meaning vision. This is a half-sided blindness in each eye. So this had to do with that image of that photo that I showed you a little bit ago. This is each half of the cerebrum receives half of the visual field. And so in an infarction, the cerebrum result in loss of half of the visual field in each eye. So homonymous hemianopia is loss of half of the visual field. And so this is what we would refer to when we say that the stroke patient has kind of a visual field neglect, where they are looking at their plate of food, but they can't really see all the food that's on the other side of the plate. And sometimes we have to turn their plate around or explain to them that they've got, you know, the food that they can see on this side. And remember, you've got your peas and your mashed potatoes over here. And so this is just another way that as nurses we can help patients navigate everyday life and make things a little bit easier for them. So cerebral infarction on one side of the brain affects motor, sensory, and visual fields of the opposite or contralateral side of the body. Now, if there is a stroke in the brain stem, this can be very complex, all right? So what we just explained was pretty straightforward. But when you have a brainstem stroke, there can be alternating hemiplesias and hemianesthesias. And here's what we mean by that. So because the brainstem controls so many autonomic functions, remember, autonomic functions are automatic functions, right? Like our heartbeat and our breathing. We don't tell our heart to beat. We don't tell our body to breathe. It just happens automatically. Infarctions of the brainstem are usually lethal. It's not compatible with life if you've had an infarction in the brainstem that causes cell death and you stop breathing and your heart stops beating. However, a small part of the brainstem can become infarcted on one side. And if that happens, it can affect the lower motor neuron of the cranial nerves on the same side, the ipsilateral side, all right? And so this kind of gives us a little bit of an image to see where we can remember when we review this slide that a brainstem stroke on one side of the brainstem can actually cause affect the lower motor neuron on the same side, but also affecting the upper motor neuron of the pyramidal tracts before they cross. So again, you'll have to refer back to our intro to neuro lecture where we talked about the pyramidal decussation and the crossing. And so if this happens, we can have alternating hemiplegias where we might have some paralysis on one side of the face and the opposite side of the body. So alternating meaning ipsilateral and contralateral side of the body. Okay, so I'll give you a second to just think about that. So remember, depending on where the brainstem stroke occurs, the sensory loss may occur on one side of the body or the other. Okay? So brainstem strokes are very complex, and we want to watch for these alternating hemiplegias and hemianesthesias. Okay. Cerebral infarction is a little more straightforward. Remember, we said it affects one side of the brain, will affect the motor, sensory, and visual on the opposite side of the body. So one of the things that we want to also consider about a primary area infarction, let's say the primary motor cortex has an area of cell death due to a stroke, that's going to result in paralysis. If we have an infarction of the primary somatosensory cortex in the brain, we're going to have a resulting loss of sensation and position senses. And so it's really important to think about the different parts of the brain and their function in order to identify the kind of deficit that the patient will have with. For example, infarction of the primary visual area in the occipital lobe is going to cause blindness. And infarction of the primary auditory area, this is very interesting, does not result in deafness because the auditory cortex on each side receives all the auditory information. And if we look at this slide here, we can see that the deficit occurs after a stroke really depends on which cerebral artery was occluded. So you can look at all the different areas of the brain where voluntary eye movement happens in the brain, where motor and speech production originate, where motor movement originates in that motor strip, sensation, that's the input, the signals that we're getting from the body, sense of smell, taste, touch, our language comprehension, our vision, our memory. All these different parts of the brain can be affected due to different strokes in different places. So, you know, a cortical infarction, we can have them in the secondary cortex and the tertiary cortex, and they can get very complicated. And so some examples of what we mean by that is that people can have a stroke where they really don't have the ability to differentiate things from other things. So a book written by Oliver J. Sacks is called The Man Who Mistook His Wife for a Hat. And it was a university professor who had had one of these deeper strokes in his brain, and he thought his wife was a hat rack. So it can be very interesting. Let's take a little bit of time to talk about aphasia. This is a partial or total loss of the ability to talk or understand what people say. It's difficult for the patient to read or write. Aphasia can affect one aspect of language. For example, somebody might be unable to remember the name of an object or unable to put words together in sentences. More often, many aspects of language can be affected at the same time. This is called global aphasia. It's the most severe form. These folks can really say few familiar words and barely understand what people are saying, and they're unable to read or write. I want to differentiate, though, between Broca's aphasia and Wernicke's. Another form is Broca's, or non-fluent aphasia. This is when people are speaking very slowly, and it takes a lot of effort for them to try and articulate words. So they will talk slow. And oftentimes they just use two-word sentences, but they know what they want to say. This is going to be very frustrating for them. So they'll, use two-word sentences like walk, dog, and it's difficult for them to form the words. On the other hand, people with Wernicke's aphasia, they have affluent aphasia, they can talk easily, okay? But they're using the wrong sounds in words, and they're saying the wrong words, or they're even making up words. So this is where you'll hear their type of speech referred to as word salad, where they can say things, they can articulate words, but they're not using the correct types of words to describe the things that they think that they're describing. So speech therapy is going to be important after a stroke. Someone can recover from aphasia without treatment. The brain will get better, can get better. However, most people do benefit from therapy by a speech and language therapist, and the goal is really to improve their ability to communicate with people. So we might use props to make conversations easier, photos, maps, draw or write things down on paper to communicate. Want to encourage these patients to take their time because this can be very frustrating for them. It takes extra patience for the staff as well to just give them time to communicate what it is they're trying to communicate. We want to encourage them to take one idea at a time. Sometimes we can create communication books that include frequently used words, pictures, and symbols. There's lots of computer technology now that can help these folks communicate as well. Memory loss can occur after a stroke. It's not the same for everyone. There may be different ways that memory can be affected. Verbal memory can be a problem where they can't remember the names of people, stories, or information about words. They can't remember people's faces or routes that used to be so simple for them before the stroke. If somebody has memory damage, they might have trouble learning new information or skills. This is anterograde amnesia. Or they might have the other form, which is retrograde amnesia, which is where they have difficulty retrieving information from the past. So I don't know how many of you have seen 50 First Dates. But in that movie, remember every morning when the female character woke up, she couldn't remember that she was married to, I can't remember the actor's name, but she was married and she couldn't remember, so she had to watch a video every morning when she woke up to remember that she was married to Adam Sandler and that they had a baby together. And so this was kind of a form of retrograde amnesia. So therapies or medicines almost never fully restore the memory after a stroke, but many people do recover at least some memory spontaneously, and others will get better through rehabilitation. Okay. So the best thing we can do for our patients is to help them form a routine. We want to make sure that they're doing very simple tasks during the same time of the day each day at regular intervals. We don't want them to tackle too many things at once, and also to kind of take breaks in between. If they have a problem forgetting frequently, it can be helpful for them to make lists and write notes, sticky notes to put on things to help them remember things. Always making a habit of putting things away in the same place where it can be easily seen or found can be really helpful for these individuals because, again, losing things can be very stressful. And having routines and putting the dentures in the same place every time, putting the hearing aids back in the same place every time can be a way to help them find the things that are really important for them. Adaptive devices can be used as well. We see a lot of adaptive devices around the long-term care facilities and the rehabilitation facilities. Here we see a Velcro spoon that's used to assist for eating, something called a scoop bowl. We can see a bent spoon here, a suction cup plate that keeps the plate on the table, a lid cup, a double-handed lid cup here. This is called a nosy cup. Grab bars can be very helpful in bathrooms and showers. We often use bedside toilets and shower chairs to help with safety. And so safety is going to be a major consideration when transferring our patients with strokes. And also after a stroke, even just routine daily activities like dressing them can be challenging. We want to make sure that we are allowing enough time to get all the activities of daily living done, not rushing our patients, not rushing ourselves. And to have patience. So I thank you for your attention today in this lecture, and I hope that you learned something about strokes, the warning signs, the different types of therapies and treatments, and how we can help these individuals live a better quality of life. Until next time, aloha.